Okay, so this is an article which is currently in press in the journal Injury, expected to be published in 2011. It's by a group of authors from the Tel Aviv University in Israel, all members of the Department of Orthopedics. Their actual titles and roles aren't declared in the article. So, by way of background and introduction, fractured neck of femur, as we all appreciate, is a major problem. Some stats gleaned from the article based in the US. Approximately 350,000 operations for a fractured neck of femur occur each year, with not terrific results in the long term in these patients. Mortality rate of up to 24% at 1 year, and approximately 1/3 of those are losing the ability to function independently and requiring placement to high or low level care. Here at Western Hospital, we have broadly two streams of management for patients who have received antiplatelet therapy of clopidogrel and aspirin. Those over at Sunshine are admitted under the neck of femur fracture unit, which is run by the geriatricians, and their policy is that all antiplatelet medications must be continued in every patient. At Footscray, we don't have a strict a priori policy for this. Instead, it's based on surgeon preference for that week, based on advice from our cardiology colleagues. For my own benefit, I reviewed what the antiplatelet drugs do and what platelets themselves do. Important in hemostasis because they form the initial plug when there's vascular injury, for example, during tear or injury to an artery or a ruptured atheromatous plaque. They then provide the scaffold for recruitment and concentration of coagulation factors. Platelets adhere to the site of injury via collagen and von Willebrand's factor, and after adherence then go through a process of release, the second phase, where chemical thromboxane A2 and adenosine dinucleotide phosphate, thromboxane and ATP, the role of which is to increase the adhesion or the stickiness of the surrounding platelets passing through the vasculature and synergistically work upon existing platelets to release further thromboxane and ADP. After platelet aggregation, thrombin increases platelet aggregation and converts fibrinogen into fibrin and cements the platelet plug, thus forming the hemostatic plug and allowing for the coagulation cascade to continue. Aspirin is a thromboxane receptor antagonist, and clopidogrel an ADP receptor antagonist. Clopidogrel we see used widely in cardiac patients after catheterization stent implants. Broadly, the usual indications for antiplatelet therapy with clopidogrel is a minimum of 6 weeks after a bare metal stent goes into a coronary artery, and a minimum of 2 years if that stent that's inserted is a drug-eluting stent. So it's also used in cardiac bypass grafting. There's a broadening trend for the use of clopidogrel. Aspirin and clopidogrel we see used together when patients have thrombotic events on clopidogrel alone. Reversing antiplatelet therapy isn't without its own consequences. In relation to when they have their cardiac procedure, they've got a 5 to 10-fold increase of a major vascular event within 1 year of that, if reversed within 1 year, that procedure. And if it's within 1 week, 3 weeks, sorry, they see between 30 to 85% mortality, which has been reported in the literature. The operations that we're doing have a propensity to bleed. Those that are on antiplatelet therapy have a propensity to bleed. Withdrawing the antiplatelet therapy takes approximately 10 days for the platelets to return to full activity. In those patients that who do have their antiplatelet therapy reversed, we see an increase of thromboembolic events. There's also described a rebound effect where the patient can become hypercoagulable upon their baseline coagulability after withdrawal antiplatelet therapy. And so at time of operation, or when we're doing our operative planning, it really becomes a risk versus benefit evaluation where we look at the complications of intra and post-operative bleeding, weighing that up against delaying surgery so that platelet function can return after withdrawal of aspirin and clopidogrel, and the higher, sorry that sentence isn't finished, and the higher rate of morbidity and mortality afterwards, after delayed surgery. So the authors have hypothesised in this article that there would be no significant excessive blood loss related to hip surgery based on whether a patient was on clopidogrel or clopidogrel and aspirin versus just no antiplatelet therapy or aspirin alone. Their secondary endpoint was that mortality and morbidity would not be increased amongst patients on antiplatelet therapy compared to those who are not. So they've designed a prospective multi-centre case-controlled trial. The inclusion criteria for their patients was an age greater than 40 years and a hip fracture, which occurred within 48 hours of presentation. They were allocated to two arms of the study. Arm 1 was patients who were on clopidogrel long-term with or without aspirin, and the second arm were patients who had never been on clopidogrel but may or may not be on aspirin at the time of presentation. Patients were excluded if they were warfarinized, had a thrombocytopenia, which is the usual definition of less than 150,000 per ml, and or evidence of a hematological malignancy. There were some other exclusion criteria, including a diagnosed bleeding diaphysis or previous evidence of hypocoagulability. It's carried out over 1.5 years and recruited 88 patients. Broadly, the patients that were enrolled in the study, Garden 1 and 2 went on to dynamic hip screw or percutaneous pinning. Garden 3 and 4 classification had hemiarthroplasty. Intertrochanteric and subtrochanteric fractures had femoral nail or dynamic hip screw. In all patients, drains were taken out within 48 hours. And demographic parameters such as height, weight, age, pre- and post-operative hemoglobin levels were also measured. The authors used the collected data to perform some calculations to make estimates and to act as surrogates for blood loss. They calculated intraoperative blood loss, and that was the volume in the suction containers at the end of the operation, plus the weight of the swabs, subtracted the volume of lavage fluid that was used during the operation. Measured blood loss was that figure, the intraoperative blood loss, plus what was collected in the drains after 48 hours. Using those two measures as corollaries, they've come up with their own hypothetical formula to try and calculate what hematoma accumulates within the operative site. And they called it the total hidden blood loss. And that was an estimate blood volume calculated by a not very intuitive calculation. They took an estimated blood volume for that patient based on their age, weight and height. They multiplied it by the pre and post HPs they calculated at time of admission and also day 7 post-op, and then they added on any transfusion they performed during that time. So the findings of the study, their derived formula for total hidden blood loss correlated well with the mean measured blood loss for all their patients. And they used Pearson's coefficient and linear regression to find a correlation between the two. So effectively they've said that our derived formula, total hidden blood loss, correlates well with what we measure intraoperatively and what comes out of the drain. Other broad findings, patients on clopidogrel waited longer for surgery in their case of 88 patients. So an increase of 19 hours average with the standard deviations and ranges seen for both. Amongst their series of 88 patients, there was no deep vein thromboses and no pulmonary emboli seen amongst those who were on clopidogrel, aspirin or neither. Overall, the measured blood loss was greater for surgery which was conducted earlier rather than later, so that which was conducted within 48 hours and that was conducted after 48 hours. And hemiarthroplasty required a greater number of transfusions afterwards. The authors then go on to elaborate quite a bit more on differences between their measured blood loss, but using the total hidden blood loss formula, comparing it between the three groups. So subgroup analyses was performed upon the two allocated groups already identified. Comparing clopidogrel and aspirin, we see a mean blood loss of difference of 300 mils. Standard deviation was quite similar, although the ranges, you can see there, are quite large, from 178 mils to 3.4 litres. Clopidogrel and aspirin was higher again, similar ranges, similar standard deviations. And patients who are on aspirin alone or no aspirin whatsoever had, again, a clinically and statistically significant difference. Oh no, I retract that last statement. They didn't quote p-values for this one, but there was a clinically significant difference of 899 mils standard deviations as reported. They also reported that those that had operations after 48 hours had less blood loss, and those that had short operations had less blood loss. Ranges were not reported for these, but p-values were. This is a pictorial representation of that same data using the box and whisker plots. The main thing to take away from this, in my opinion, is that the clopidogrel and aspirin groups had significantly more blood loss, with a greater range of blood loss compared to the other groups. Medical adverse events. The study was, you'll recall the secondary hypothesis or secondary endpoint of this study was that there would be no difference between the groups in terms of medical adverse events, whether or not they were on antiplatelet therapy. I'll draw your attention to the main ones that we from a surgical perspective, mainly look out for. And you'll see that in terms of leaky wounds post-op, those that were on antiplatelet therapy had increased numbers of wound discharge if they were on antiplatelet therapy, the highest number of those being on clopidogrel alone. So 19% of the 88 patients in the series had wound discharge. Dreaded wound infection. 3 cases seen out of 88. Again, only in those on antiplatelet therapy. Surgical wound bleeding. Again, 2 cases overall, and only seen in those patients that were on antiplatelet therapy. That's just so moving away from the findings of the article, I'll move on to my analysis of it. So Pearson's correlation was used as a coefficient to compare the surrogate of total hidden blood loss against mean blood loss, which is a reasonable statistical test to use. Multiple linear regression was used to measure independent variables contributing towards those 2 figures. Logistic regression again was used for independent variables, the total number of red cells transfused and the total hidden blood loss. And they used an analysis of variance to look at the differences in baseline demographics between the antiplatelet treatment subgroups. All of which is a reasonable statistical analysis plan for this cohort. Things were omitted though, sample size calculations to looking to see whether the study would be sufficiently powered to detect differences based on previous studies. If they were performed, they weren't reported. Despite clearly stating that there will be an allocation to 2 groups, we saw from that slide with the table on it, there were multiple subgroups analyses predisposing towards type 1 error. Yes. The author's conclusions are that the patients treated with clopidogrel and clopidogrel with aspirin had greater amounts of perioperative blood loss when they operated on without delay. Early intervention was associated with greater blood loss. Short surgical time was associated with less blood loss. And the motherhood statement of, we recommend that following a policy of discontinuing antiplatelet drugs and delaying surgery, the surgeon must weigh the risks and benefits for each individual patient. By staying close to very safe conclusions, the author's evidence does wholeheartedly support their conclusions, but I don't think that they particularly add a great deal more to what we would consider from looking at this issue from first principles. How does this compare to other studies? You recall that there was no DVT or PE in our series of 88 patients who had fractured knobs and emergency surgery, which I found quite surprising. Previously found that there was 1 case of DVT and 2 cases of pulmonary embolus in 17 patients who had their clopidogrel ceased. Another study found a 30-day mortality of 30% amongst 21 patients who underwent hip surgery on clopidogrel. One statistic I didn't highlight was that only 2 patients out of this series of 88 actually died. None died within the perioperative period, and those that did die died in after they reached rehab. There was no increased transfusion requirement between 29 patients who were on Clopidogrel and 32 matched patients before 5 days in a retrospective audit. And another study found that there were similar rates of mortality and complications in 21 patients on Clopidogrel and 114 patients not on Clopidogrel. Whether or not our study today, the Royal Analysing, is consistent with that is probably not significant, given that it would be underpowered to detect complications in the Clopidogrel. So my conclusions after reading this article, the study allocation scheduled, while appropriate to get past an ethics review board, isn't particularly helpful for our patients because they didn't actually stop any patients Clopidogrel or aspirin. They simply took patients who were already on these drugs and left them on them and compared them against patients who weren't already on them and left them as were, and then looked at the complication rates down that track. So already you're not particularly changing, you're not performing an intervention, it's more of a descriptive study, which isn't overly helpful. And secondly, you've got two groups whose baseline predisposition towards developing thromboembolic events, i.e. pre-existing atheroma and risk factors for cardiovascular disease, who differ at baseline. The secondary endpoints, medical adverse events, which I think probably for all of us here are much more interesting and important than the volumes of blood that are lost, probably should have been the primary endpoint. And this study was underpowered and ill-designed to detect any differences between the two groups and a complication rate. I found the complications difficult to follow. When I used the formula for total hidden blood loss using some reasonable numbers from an orthopaedic patient, it yielded a strange result. So if you can't reproduce figures yourself after reading the article, either I'm flawed or the formula is not well described. And when we look at their findings, a clinically significant difference between antiplatelet groups of about 1 unit, however, I think is clinically significant. However, the wide ranges we see for this figure they give of total hidden blood loss remind us that the antiplatelet therapy isn't the only cause of intraoperative blood losses. So remember the range for patients who are on Clopidogrel and aspirin went from 170 mils up to 3.1 litres. So these patients aren't designed the same. It's the point I'm trying to make there. As I just mentioned, I think that a difference between groups of 1 unit or 3 units of blood which is lost, presumably into deep tissue, is significant from our perspective because that represents further hematoma which can act as a nidus for infection if you get a superficial wound, in addition to the pre-existing burden the patients might already have. Also acts as a distraction between your wound closure, possibly delaying wound closure and healing. I'm very, very surprised that there was no pulmonary embolus, deep vein thrombosis, and in this cohort, and the low numbers of stroke or acute coronary syndrome. Having said that, we did leave them on their antiplatelet therapy. So either they're occurring and they weren't picked up, or that the comparison groups weren't clinically relevant to pick them up in the first place. I admit that I've harped on the fact about we're worried about wound breakdown and discharging wounds and bleeding wounds. Cause and effect is difficult to establish in these patients. I did say that they were skewed towards patients on anticoagulation therapy. Pinning it onto aspirin and Clopidogrel alone may not be fair on poor old aspirin and Clopidogrel. Especially in these patients, they may have comorbidities such as diabetes, which would predispose to those problems anyway. Overall, I don't think this is a terrific article. I think overall the design was somewhat clumsy, although practical to get ethical approval and to write up. I think it still provides, there is some value in it, and those measurements of blood loss, whether or not their formula they derive for finding hidden blood loss is valid or not, it does add to the literature and helps to guide us when we think about these patients. I think the most useful tool that this could provide is as a basis to design a broader prospective randomised controlled trial examining this issue further. The main question in my mind when I picked up this paper that I wanted to have answered wasn't answered, and that's that if we stop the antiplatelet therapy, will we see more adverse events? And if we let it go, are we going to see more hematomas, failed wound closures and wound breakdown? So I think that question's still outstanding at the end of this article. Questions and comments?
Thank you, Mark.